have the same opinion. And in clinically identified lymph node metastasis, radical lymph node dissection is considered a standard therapy. Is that true?
I think, oh, sorry.
Oh, go ahead. No, go ahead.
I think according to the data we have that we have no benefit for survival up to now. I think we cannot state this as a standard treatment.
No, moment, just back, perhaps to avoid any misunderstanding. The standard treatment is clinically identified lymph node metastasis, not sentinel node positivity.
Yeah. Okay,
That's controversial, but in involved lymph nodes which are clinically apparent, which are metastases, then of course you remove these metastases.
Yeah.
Yeah.
When you talk about radical lymph node dissection for very extensive lymph node, we do not perform extensive radical neck dissection.
You do it in a modified.
Modified, and if there is a very large lymph node, which you usually do not do extensive surgery, I think what you report, everybody agree about that. No? You do radical neck dissection, complete for a large lymph node, you do a radical neck dissection?
Yeah, I think for us, the decision to whether or not to perform a radical neck dissection is dictated by the proximity or involvement of the spinal accessory nerve or the internal jugular vein by tumor. Oftentimes you have a tumor in the posterior lateral aspect of the scalp with large metastases in the suboccipital region. We do radically remove that, but we don't necessarily remove the spinal accessory nerve or the internal jugular vein. So it depends on the extent of the disease. So in that regard, I would take issue with the statement that a radical neck dissection is the standard of care. I think Dr. Byers and myself in the past have shown that when the procedure is carefully done, a modified radical neck dissection and a radical neck dissection really have no difference in terms of the final outcome. And we're beginning to see today more and more efforts to use selective neck dissections in the treatment of patients with positive nodes in melanoma. And while the experience is still early, I think there is room for a selective neck dissection when, for instance, you have a positive node in the tail of the parotid or a positive node in the submandibular region and no positive nodes clinically or radiographically anywhere else in the neck. In those cases, a selective neck dissection of levels 1, 2, and 3 or even 4 may be appropriate. And there is beginning to appear evidence that that may be the case.
Section. And I think that prospective randomized study, which was not exclusively head and neck and mostly not head and neck, it seemed that the outcomes were better, survival outcomes for those patients treated with early burden microscopic disease versus those treated with positive nodes when they recurred. When you look over it all, sentinel node didn't have a survival benefit, but those with positive sentinel nodes clearly did better than those who were allowed to fail in the neck and then were salvaged. The second point I would make in terms of selective or neck dissection after a positive sentinel node, that's probably a 20% rate of having a second positive node after one microscopic positive node and sentinel node biopsy. So you need some treatment, whether that needs to be surgical or radiation can be debated, and I think either one of them is probably good. The last point I would make, I see a lot of melanoma. I almost never do a radical or modified radical neck dissection, even for bulky disease, if it does not impinge upon those structures mentioned by Dr. Medina. And in Matt Ballow's work, which is built off of Dr. Eng's work, it's retrospective evidence, but large series, we get 85 and 90% local regional control with selective neck dissection, lumpectomy, or even no nodal dissection for people with positive sentinel nodes. So I think, again, those patients do much better in terms of local regional control than they do for survival.
Thank you for this comment. Please.
I'd like to step back a little to the sentinel node question. The paper that's published by Dr. Morton is actually published with a comment from the editor of JCO saying that the data that's presented in that trial does not support the conclusion of doing a elective dissection based on sentinel node positivity or negativity. The question I'll ask the panel, therefore, if you look at the accumulated high-level prospective data, there is no therapeutic benefit to doing either sentinel node biopsy or neck dissection in an N0, clinically N0 setting. Should you be doing sentinel node if you don't have a trial or some other adjuvant therapy to follow the sentinel node biopsy if you accept the data that there isn't a therapeutic advantage that's being delivered by the sentinel node biopsy itself?
That is the question. I mean, if we should abandon it or if we should follow it. Most centers do it, and they continue to do it in the way you mentioned it.
Well, I think this calls for having a candid yet informative discussion with the patient. Because melanoma patients, unlike the run-of-the-mill head and neck patient with squamous cell carcinoma, it's usually a younger individual, better educated. I usually sit down with them and explain the facts. And many of them are already knowledgeable of the facts that are in the internet and whatnot. I think the question you bring up, Boo, is very, very important. Today, like the trial that you are conducting, the follow-up study to the sentinel node biopsy trial by Morton is just that, sentinel node positive randomized to dissection versus observation. So in that context, yes, you should do a sentinel node biopsy if you're participating in that study. If you are not, I think we need to soften the language in these guidelines, and the NCCN guidelines have done that. And they don't say that a sentinel node biopsy should be done. They said that sentinel node biopsy should be discussed with the patient. Because you discuss with the patient, you say, I can tell you whether your prognosis is that you're going to be alive 83% or 53% versus doing this operation, and many patients don't even grasp that notion. And you should not try to sell that operation as, well, you're going to have a better survival if this. And with regards to the point that Jeff brings up with the Morton trial, that a subgroup of patients that have a sentinel node positive that had a better survival. I think we cannot take that statement or that conclusion at face value. And the reason is, and the main criticism to that report is that the initial design of the study called for randomization of patients with melanomas that were thicker than 1 millimeter in thickness. And 2,001 patients were randomized. Yet the third interim report that comes to this conclusion only studied 1,347 patients. Why were 654 patients eliminated from the analysis? And why was arbitrarily that range of 1.2 to 3.5 picked is what has been brought to question in the main criticism to that study. And also, since we're on the topic, in those results, you compared microscopically found positive nodes in the sentinel node biopsy group with patients that were watched and wait until there was clinically evident palpable disease, which many of us don't do today. We don't wait and see till the big node is palpable. We follow those patients with ultrasound, CT scan, or whatever, and the patients in the trial weren't followed that way. And if they had, maybe the results would be different. And in fact, the subsequent study calls for the observation of the patients not clinically, but with serial ultrasounds at the original trial should have been perhaps.
Yesterday morning I had such a discussion with a patient and he refused sentinel node biopsy. He had a melanoma preauricular, and in the lymphoscintigraphy there were several nodes positive with low counts, but we discussed that all for him, potential benefit and the studies. He was very well informed. Many patients are internet informed, and he decided to have a close follow-up but no additional surgery.
One comment, it's pretty clear now from the discussion and also from discussion the other round that there's no therapeutic benefit. However, one benefit for the patient could potentially be if the sentinel node is negative. then it may modify the follow-up examination. If you have a 2 millimeter melanoma and negative sentinel node, then the cure rate is so high that you don't need these extensive follow-up schedules. So that may be an information that may be of value to the patient, not a therapeutic implication, but for the follow-up.
It's always a positive information for the patient if a node is not involved, and so he has at least this benefit. But the question is also, if it would be positive, or if he has a worse prognosis, how can we help him? And perhaps we should come to the end, and have a short statement, because there is nothing much to tell, unfortunately, about stage 4 disease. We can excise solitary metastasis. We can do radiation therapy on metastasis, but we could also do chemo or chemoimmunotherapy, and all meta-analyses unfortunately come back to dacarbazine, and perhaps we can have a final comment from our 2 oncologists, what their view is of today's chemotherapy, first line or second line in malignant melanoma.
I think that all clinical trials above dacarbazine has been very disappointing in randomized trials. Neither combination therapies nor combinations with biologicals, interferon or IL-2, have shown an advantage for overall survival. So now we have come back to only 2 drugs, at least, to dacarbazine and temozolomide. And what I think might be discussed is whether temozolomide might be an alternative for melanoma in head and neck, because according to the literature, the risk for cerebral metastasis might be higher in this group, and temozolomide overwhelms the brain barrier. So this might be possibly discussed. I am hopeful that tyrosine kinase inhibitors, new agents, might be possibly a little bit more efficient. But for this, I think we have also to define subgroups which might benefit of these new agents. But up to now, we are very limited in therapy.
Unfortunately, not everything what is beneficial in renal cell carcinoma is beneficial in melanoma, but perhaps Oli Kailos can.
Well, I just can report from a meeting we had at the NCI in 2005. There was a NCI State of the Science meeting to discuss melanoma treatments and to discuss which drug we would take forward into phase 3 testing. And I think the most important outcome of that meeting was that everybody regarded DTIC, dacarbazine, as reference treatment, not as standard treatment, because the benefit also for dacarbazine was never shown, but it is a well-tolerated reference treatment. And the second outcome is that investigational agents as first-line treatment are justified, which is describing the dilemma that there's no standard, even not a standard first-line treatment. We have things we can try, but there's no standard. It's just dacarbazine is just a reference treatment.
So basically, we all include patients in ongoing trials. And this might be a final comment on the situation in advanced or in more advanced melanoma. We are more and more advanced with the time. I thank the panel, I thank the organizers, and I thank the audience, and I congratulate the organizers to this wonderful meeting. Thank you.